the last of in this lecture series. And today we're talking about harm reduction and overdose prevention. Again, with a focus on patients who you are meeting and interacting with during a hospitalization. So just a couple of reminders are that all of these recordings of these lectures are available within a day or two after we complete them. And there's a YouTube site where you can access all of them. So if you missed any of the other lectures, or if you want to go back and look at them again, or to use them in your own teaching or what have you, these should be accessible to you in an enduring way. And you can always contact us at the HBOT email if you're not sure where to find them. I wonder if somebody from my team could put that email just into the chat so people have it handy.
Sure.
And the other housekeeping stuff is that there's a request to put into the chat your name, role, hospital, and email address. So that we can keep attendance just for ourselves about who's attending from what hospital. And there is CME for this session, as there has been for the others, and we'll give details on that at the end about how to sign up for CME. And I think with that, we'll talk about ground rules and get rolling. So as always, asking people, if you don't mind, to turn on your video. I know sometimes this is the lunch hour and you just want to break from it. But if you are here, it's nice to see faces and not just a wall of black boxes. Obviously mute yourself when you're not speaking. Changing your name to actually put your name in it, if relevant. And we will have some opportunity, a couple of places probably will all ask you questions. But if you have a question, feel free to pipe up. If that's not comfortable for you, put it into the chat, and someone from the NYU team will bring it up for the rest of the group. I can't see the chat well when I'm sharing slides, but they will be keeping an eye on it, as with the other sessions. If you're talking about patients, please don't share any PHI, and really inviting your questions so that we're here doing this so that we can all learn. So nothing is off limits to ask about. We encourage it. So the objectives today are to talk about sort of the definition and the overall concept of harm reduction, understand how harm reduction approaches can help engage patients who we're meeting, say, in the hospital, who have opioid use disorder. We're going to talk about some specific harm reduction interventions, including naloxone for overdose prevention, syringe exchange, and other harm reduction strategies, and really focus in on how to incorporate this into your work in healthcare settings. And also, for me personally, so I'm a primary care and addiction medicine physician and a researcher. And my work and clinical practice has been shaped so much, actually, by my experience when I was not even yet thinking about going to medical school, do it as a syringe exchange volunteer in New York on the Lower East Side in the mid-90s. And what it really impressed on me, first it stimulated my interest in then working in addictions and trying to improve addiction services. But really, in terms of my patient interactions, it was so important to sort of see what it's like to meet people where they're at, to work with them on making whatever incremental, positive changes they're ready to make, and building the trust and just better communication that comes with that. So I carry that with me every day when I interact with patients, and hopefully you will too, just by thinking more and focusing more on this perspective. So this is sort of, a checklist that has been recommended that you might go through if you're doing consults for addiction in the hospital. And so, we always start with history, and then, think about and present to patients treatment options, talk about overdose prevention, talk about prevention of other complications like infections. And just making the point that all of these middle boxes all can fall under the umbrella of harm reduction. That harm reduction, services and specific interventions exist on a spectrum that includes, prevention and spanning all the way to treatment. And the important thing that makes all of this harm reduction oriented is that it's working with patients on what their goals are and what's realistic for them at this moment and what they want to do. So what is harm reduction? Many people talk about harm reduction as more of a philosophy or an approach, but I think for us here, thinking about it as a set of strategies and ideas aimed at reducing negative consequences associated with substance use. And a key aspect is that it acknowledges that abstinence should not be a precondition to accessing health services, and acknowledges that there are ways that people who use drugs and alcohol can improve their health even outside of changing their consumption or stopping entirely. And it's not so different from how we address lots of other health issues. I would say most other health issues, in primary care, for example, we work on smoking cessation a lot. That's very harm reduction oriented. But even something like, working with patients to lower their cholesterol. We talk about a range of things that they can do. We talk about changing it in diet. We talk about medications. We talk about, getting more advice from a nutritionist. We present an array of things that they could adopt, and patients will choose and be able to do different things. And any of those changes, some things help more, some things help less if the goal is to lower cholesterol. But really the goal is to have enhance overall quality of life and overall health. But just to make the point that we negotiate and offer treatment options or behavior change options as part of just routine medical care all the time. But when we're thinking about harm reduction as it relates to patients with substance use, the harm reduction movement really kind of got going in the 80s as a grassroots movement with strong social justice orientation, led by people who use drugs, and with strong links, in the US at least, to AIDS activism and groups like ACT UP. And key is that the valuing and honoring the people who use drugs are the experts in their own experiences and need to be at the table. And it is, as it's evolved, there's been a lot of research on harm reduction strategies and interventions, and lots of evidence-based approaches that fall under this umbrella. And I think when I talk to my colleagues in medicine, there's often a fear that by talking about safer ways of using substances, that were green lighting it or condoning use. And there's strong evidence showing that that is not the case. The talking about drug use or how to use drugs more safely is not enabling, and in fact can open the door to having more constructive conversations about improving health, conversations that can sometimes even lead to talking about using less. The key to all of this working is, to honor the patient's wishes and meet them really where they're at now, and to accept that immediate goal may not be abstinence, but to focus on, in a patient-centered way, what is important to you now, and how can we support you and your health now. And being ready and being informed enough really to talk about safer use just to sort of know what you're talking about. It's not difficult to learn. We'll talk about some of it today, but also offer some resources that are great guides for how to counsel patients on things like safer injecting practices. Just having some background knowledge of that will enable you to engage patients in more useful conversations about it. Underneath it all, being like compassion, and I would say respect for the patient, drive the discussion, and to just beware of slipping into saying things or communicating in a way that is judgmental. And just noting that these approaches apply to any substance, and I would say apply to essentially any health behavior too. And we do practice harm reduction all the time in our daily life. And we talk about it all the time, though not always with respect to drug use. So wearing a seatbelt is probably the best example of it. We would all be at least use of dying in a car accident if we did not get in a car. But we all get in cars. It's part of our life. It's important to our quality of life and our livelihood. And so when we get in the car, we put on our seatbelts, which makes us less likely to die in a car accident. And really, I think that the parallel is very clear to talking about ways of using drugs more safely. Also, having sex more safely with condom use, taking a taxi home if you've been drinking, wearing a bicycle helmet. There's lots of examples of harm reduction in all of our daily lives. What has really heightened the importance currently in talking about harm reduction is the overdose crisis and the huge increase in overdose deaths that we're experiencing now. Though I will say, going back to the roots of what we now call the harm reduction movement, is HIV and terrible rates of transmission of HIV that really kind of stimulated this this strategy that has continued and is just becoming increasingly relevant as we go forward. So, fentanyl in the drug supply is the biggest driver of overdose deaths now. And this, but just to state it again, fentanyl is 30 to 50 times, sometimes 100 times more potent than heroin. And it is now contaminating much of the illicit drug supply, particularly almost always in heroin at this point, at least in the New York City area, but also contaminating stimulants like methamphetamine and cocaine, and pressed pills as well are now increasingly being found with fentanyl in them. And from an overdose prevention, overdose reversal standpoint, it does require higher doses sometimes, or more doses of naloxone to reverse overdose when fentanyl is involved. And I just think it really raises the bar on what we're doing and how we're engaging patients in talking about their risk of overdose, because the risk of death is so much higher now. So to talk about, really what kinds of services are we talking about when we say harm reduction services? I mean, I think overall, harm reduction is an approach, not a service. And oftentimes, though, when you ask someone, what's harm reduction, they say syringe exchange is harm reduction. And syringe exchange or syringe access is part of harm reduction. But there's certainly a whole set of well-defined strategies in addition to the kind of philosophy and general approach with people. So the priorities are to prevent overdoses and overdose deaths, to reduce infectious disease and other health complications, to link people to other health services that would benefit them, and to improve the dignity and have respect for people who use drugs, are what sort of the fundamentals underlying this. And the specific services can include, in the diagram, safe drug use and overdose education, drug checking. Now we're talking about fentanyl test strips increasingly, but often there's been drug checking, like at parties, drug testing, so that people know what they're ingesting before they use it. Sterile syringe access, supervised consumption sites, which we're now talking about in New York as overdose prevention centers. Safe supply, which has come into greater attention, especially with the increasingly toxic drug supply due to fentanyl contamination, talking about how to allow people to use drugs that are less dangerous, and naloxone distribution as part of overdose prevention, overdose reversal. So we're going to talk in a little bit more detail about a number of these specific strategies, and starting with overdose prevention education. So this outlines the steps. The goal is, in terms of counseling people, talking to them about how to reduce their risk of overdose. We talk about avoiding using multiple substances at once, in particular opioids in combination with benzos and alcohol, particularly if you throw a stimulant into the mix, is sort of a common combination that's driving the overdoses that we mostly see. Talking with patients, especially patients who have been in the hospital or in rehab or in jail or prison, about the increased risk of overdose due to the loss of tolerance to opioids, and strategies for addressing that very risky situation when they may first be returning to use, or using sort of a plan one time, but without the same tolerance that they used to have. Talking about avoiding using alone, trying to get your drugs from a known source, though acknowledging that sometimes the people who are selling drugs may not themselves know what's in it, which is we're seeing a lot with fentanyl contamination now. To talk about what chronic diseases can increase the risk of overdose, like pulmonary disease, because it's already sort of one hit to the respiration, which is first affected by overdose. Talking about differences between opioids and how long-acting opioids are a higher risk for overdose often, and methadone being one to focus on here, because it's not only long-acting, but it has or complicated metabolism, and it can stick around and increase the risk of overdose for some time. And being aware, especially now, really that any drug could contain fentanyl, even something that looks like a pill. We talk about recognizing overdose to patients. This is part of the very brief training that we do, or education that we do when we're distributing naloxone kits. So, calling their name, doing a sternal rub if they're really not responding, looking for slowed breathing, turning blue, and pinpoint pupils are some of the main signs. And then talking with patients about what to do in response. So this is the list that we go through with patients: calling 911. And one thing I always talk to people about when calling 911, that you place the call and say, someone doesn't seem to be breathing or doesn't seem to be responding, not making the call saying, I think my friend just overdosed, because you want to make sure that it's the ambulance that shows up and not police. Putting the person in the recovery position on their side, telling them that you're going to use naloxone in case they are still able to hear you and process that, administering naloxone, and talking about rescue breathing, and ideally staying until help arrives, but also talking through what to do if they're not able to stay. And there are really good pamphlets that the New York City Department of Health has put together. We have links to those resources at the end of this, but it goes through in a very clear way, explaining to people what the basic steps are, including what we're going through now. So Narcan is probably familiar to most. Now mostly given in this context as a nasal spray, though there are injection forms that we used to use more often. The expectation is that when given, if what you're doing is reversing an opioid overdose, it should be active within a couple of minutes. If it's not active within that time, then you're likely dealing with something else, or maybe the naloxone has been given, not gotten delivered properly. It only works on overdoses, on the opioid aspect of the overdose, and that fentanyl may require repeated doses and sometimes higher doses as a result. So how naloxone works is it is a strongly binding opioid antagonist. So it will displace any other opioid that's sitting on the receptor and prevent, for the time that it's there, occupying the receptor will prevent other opioids from binding. And by doing that, it will reverse the respiratory depression that is the main thing that is the cause of death in opioid-related overdose. So it should be active within a couple of minutes, but important to know that it only lasts for up to 90 minutes. And so particularly in people who have an overdose with a longer acting opioid, 90 minutes isn't very long. And this is something that's important to point out as part of your overdose education with patients, that this is sort of one of the strongest reasons for making the call to 911 and coming into the emergency department, so that they can be monitored past that point that the naloxone wears off, because it's quite possible to go back into overdose, because really the opioids haven't been metabolized all that much in that period of time if they're longer acting. In New York, we are fortunate to have a pretty good Samaritan law, which provides protection for when the call is made to 911 in the case of overdose. So it offers protection from prosecution for the things on this list. So importantly, for possession of up to 8 ounces of narcotics and paraphernalia. It does not necessarily protect someone from being arrested or from probation or parole violations, open warrants, other issues, legal issues related to immigration or child welfare. So it's not completely comprehensive, but it is in place and does offer some protections. Talking now, moving from overdose prevention to talking about syringe service programs. And there are lots of examples of them, and we have some very long-standing and really excellent syringe service programs, harm reduction programs in New York. So we're fortunate. So these started, like I said, really in the 80s with a realization that sterile injection equipment can reduce the risk of acquiring and of transmitting bloodborne infections. And there's been a lot of research dating back to the late 80s, early 90s, looking at reductions in hepatitis C and HIV transmission, showing about a 50% reduction for people who use syringe service programs. This is one systematic review, and just showing that overall there's strong evidence for reduced HIV infections, and just pointing out that some of these early studies and some of the best done really were done in New York City by Don Descharlet and his research group. And unfortunately, this is still highly relevant, and syringe service programs remain controversial, even though there's a lot of experience and a lot of evidence supporting them now. This is a fairly recent and kind of sad history from Indiana, Scott County, where there was essentially no HIV in the drug using population. There was an initial diagnosis, and then a small cluster was identified in early 2015. And quite quickly, there was no syringe service program there, but quite quickly they moved to declare a public health emergency and to begin syringe exchange. And once syringe exchange got up and running, which happened, again, quite fast, that they started in April, and by July, we're distributing over 35,000 syringes. Once it got up to a reasonable level, it really stabilized the outbreak. So you go from this really exponential increase in cases with a sharp uptick to a rapid stabilization, really with the change attributed to the opening of the syringe program. But despite that great success, the program was closed in 2021. So just making the point that there is still a lot of misunderstanding and misplaced controversy about this intervention. Also important, I think, for us, as healthcare providers in particular, to recognize that I think there's a misconception that harm reduction programs or syringe service programs are all that they're doing is handing out syringes. And just to be clear, handing out syringes is an effective public health intervention, but the programs do much, much more. And if you can, visit a program, I really highly recommend it, because You get an understanding of just how much they're offering to people, including, drop-in space, food, counseling, groups, yoga, acupuncture, buprenorphine treatment. Often it's really very inviting and very comprehensive, and includes distributing sterile syringes and teaching people about how to use drugs more safely, but much more in terms of the support and sort of welcoming that they offer. And among that spectrum of services, they make a lot of referrals to treatment, and there's been a fair amount of research on that also. So new users of syringe programs are 5 times more likely to enter drug treatment and 3 times more likely to stop using drugs than people who don't use these programs. So, it's a question that has been examined because of the concern about these programs encouraging ongoing use. And the evidence is quite to the contrary. In fact, once you begin to engage people and give them ways of improving their health, then other types of behavior change become much more in reach. Safer injection practices is another thing that for people who use syringe programs, a lot of this education is done there. But we as healthcare providers can talk about it too, and to give effective advice on this. And so it's things that you largely know from medical training, but it's just a shift of the context and some of the focus. So engaging patients and talking about how to minimize overdose by not using alone. If you're with a partner, to go one at a time instead of using it exactly together. Having a plan and using a small amount at first as a tester dose to know the potency. Talking about ways of reducing infection risk. So, much of this we're familiar with is, using an alcohol wipe on the skin, talking to people about, how to wipe, to not sort of rub it around, but actually rub it away. Oftentimes people are using unsterile water from a tap, or often like a toilet, or and so talking to people about how to use the importance of using sterile water and how to access that. And syringe programs will give out vials of sterile water usually. Avoiding, using lemon juice is common to help to dissolve the drug. Talking to people about using a vitamin C tablet instead, because it's a more pure form and less likely to cause problems with the veins. Using a clean filter and a filter that's not going to break apart into sort of cotton strands that can cause problems in the bloodstream and endocarditis. Using one needle per use is the strong preference, but then also talking to people about what to do if they are forced to reuse their needles, and talking about how to dispose syringes in a plastic container. So these are things, again, there are good handouts, particularly from the Harm Reduction Coalition, and there are links at the end of this presentation about these. But this is a way of engaging people, especially people who maybe are rejecting the other types of help you have to offer. And engaging in a conversation about how to use more safely, how to inject more safely, is a way of really building trust, as well as providing or reviewing some useful information with people, and can really help to break down sort of the barriers that can make it difficult sometimes to engage patients. And just a reminder that there are harm reduction supplies. It's not all about injecting equipment. That most of the harm reduction programs will have supplies available, for example, for sniffing drugs, sterile straws being important, and for smoking. Recognizing that the other types of equipment that people use, especially if it's causing breakdown of mucous membranes, burnt lips, trauma to the nose, that those are ways of transmitting bloodborne infections also, and particularly hepatitis C being so much more easily transmitted even than HIV. And there are, if we're talking about HIV, there are certainly other methods in addition to using sterile equipment. And PrEP is one that is underutilized but effective for people who inject drugs. So it can reduce HIV risk by 74%, but it's still the uptake of PrEP for people who use drugs, or really the access to it, has been limited. But it's something that you can strongly consider offering. And the drugs are the same as what we use for PrEP for sexually transmitted HIV. And this is one of the more exciting events for us in New York City in particular has been the opening of the first US authorized supervised consumption sites. So we call them overdose prevention centers in the city, but oftentimes people will refer to these as safe injection sites or supervised consumption sites. And they provide sterile supplies and supervision when people are using their drugs. Supervision meaning that there's someone there if you are in overdose, that there's someone there to see it and to provide, they're trained and can provide assistance and keep you from dying. And this has been an intervention that's been widely adopted in other countries. There's over, I think, 120 overdose prevention centers worldwide, and they've been well studied, particularly the one that's shown in the picture here, which is from Vancouver, BC, called Insight. And the studies have looked at, sort of overdose rates in the larger population, and have shown that the opening of these sites itself has driven down overdose rates. And you have likely seen this, but we now have the first 2 sanctioned overdose prevention sites in the US, in East Harlem and Washington Heights, with hopefully more coming to the city soon. And the other states are working hard to open similar services. Rhode Island's legislators authorized opening a site, and so they should be opening one soon, but also efforts in Philadelphia, San Francisco, many other cities. So it does seem like we've reached a point, and unfortunately we've reached this point because overdose deaths have become so strikingly bad. But it's nice that we have one of these very strong sort of tools now in our toolbox to be able to offer. One other thing that's also pretty new, I would say, on the harm reduction interventions front is fentanyl test strips, which you may have available in your hospital. There's some access to them in New York City through a Department of Health program, And the syringe programs have them. Oftentimes, some of the emergency departments and addiction treatment programs are increasingly having these to give out. But there's instructions about how to use them, which are important to look at and to be comfortable with. But what they do is it allows people to check their drugs for fentanyl. They don't tell you the concentration of fentanyl, so it really is just like a yes/no answer. But in New York right now, it seems that anything sold as heroin is almost always testing positive for fentanyl. Doesn't mean that it's 100% fentanyl, but that it has fentanyl in it. But particularly helpful, for stimulants, since fentanyl is now contaminating, cocaine or methamphetamine or pills, where you wouldn't expect an opioid to be at all. So particularly high value for people who are using stimulants and not opioids. Since without opioid tolerance, the risk of dying of a fentanyl overdose is just incredibly high. And the conversation, as I alluded to earlier, has also turned to talking more directly about having a safer drug supply. Just acknowledging that the illicit market is unregulated by definition, and that people are using drugs of unknown potency, and that are contaminated, including contaminated with synthetic opioids that can kill you. And so there's been a very active conversation in Canada, particularly around BC, about this, with increased overdoses in the midst of the COVID pandemic. But something that is hard to overcome. We can test for fentanyl, but we can't currently tell people what to do if they can't access, if they're not ready for, say, medications for OUD treatment, but are continuing to use drugs that they buy on the illicit market, that we have to just acknowledge that those drugs are highly toxic in ways that are unpredictable and that the user can't anticipate. So we're going to talk briefly about how to sort of apply some of this in your work. And then in the last 10 minutes today, we're going to leave some time to step back actually from the teaching part and to tell you about the study and about your hospitals that are participating in this work with us. So we're going to end on that today. But first, just to quickly talk through a case that is something that you might encounter in the hospital, see if we can apply some of these harm reduction interventions, think about how to use them quickly with this case before we wrap up. So this is a case where you're called to admit a 29-year-old woman with polydrug overdose complicated by aspiration and left arm cellulitis. She was found unresponsive in the bathroom of a restaurant with a syringe, cooker, and filters. She works as a waiter and has been injecting heroin daily since the age of 23, uses cocaine on the weekends, drinks alcohol after work, sometimes trades sex for drugs when money is short. She's prescribed clonazepam, clonidine, and gabapentin for panic disorder and mood stabilization. In the past was treated with methadone and with buprenorphine during pregnancies, but then left treatment after. And her intention, which she is quite clear stating, is to use again after being discharged from the hospital. And you've used all of your best skills around motivational interviewing, but she's not interested in treatment at this time. So how can you constructively engage her? And in the interest of time, I'm going to go straight to kind of sort of some options, which are to, this is sort of your set of what you can offer. So like we've been talking about, to engage her in talking about, how she uses drugs, and to educate or to reinforce, safer strategies, including safer injection practices, not using alone, tester shots, PrEP, sort of these range of health protection interventions that we can offer. Asking her about overdose and helping her to solidify a plan to reducing overdose risk and to helping others, making sure she has an naloxone kit, talking about sexual risk, condoms, and importantly, post-exposure prophylaxis for HIV, PEP, and pre-exposure prophylaxis with PrEP. Talking about intimate partner violence, which is a common experience, a common source of trauma for people who inject drugs. Talking about polypharmacy, she's using sedatives plus benzos plus alcohol plus opioids, and sometimes you can get permission to talk to the people prescribing those medications, but even if not, you can engage the patient in talking about what combinations really do increase her risk of dying from overdose. And of course, talking about what treatments are available when she is ready, and that there are a range of options, and making sure that the patient knows at the point that they do want to start to think about treatment, would know who to call or where to go. So that's the last piece of it, is talking about linking patients to ongoing harm reduction. So first, I think an fairly easy one that we can handle is to make sure that patients don't walk out of the hospital without a Narcan kit and a plan. Getting to know your local harm reduction organizations, and we'll give some links at the end here, but just like knowing who's in your community and getting acquainted with the services they offer is a great thing to do, and to be able to then talk to patients about what they might find there if they were to go. And talking about, there's the standing order for getting naloxone from pharmacies, Good Samaritan laws offering some protection for calling 911, even when drugs are involved, and educating on safer use and overdose prevention, of course, and most importantly, respecting the patient, and working with what they're ready to work on that's a positive change for their health. So the takeaways are that this is part of our practice. We practice harm reduction in our daily lives, and we especially practice it in medicine all the time. So don't think that this is something that you make a referral, tell patients how to get to the harm reduction program. This really is in our wheelhouse. And it's integrated with all of the best practices for taking care of people with substance use disorders. And that you can quickly educate yourself about what the local programs are, about how to talk to people about reducing their risk of things like overdose or injection related complications. And it's really helps to build rapport and frankly overcome some of the frustration that you may feel like that you don't have anything to offer to patients, because you always have something to offer if you're willing to engage them kind of on the terms at which they're ready to be engaged today. So these are links to some good resources. There's lots more on the web, but For National Harm Reduction Coalition, there's a link to them with a nice website of resources, but also you can follow it through to local programs or local resources. In New York State, actually anywhere in the US, if you go to this NASAN map and put in your zip code, it will show you all of the syringe service programs in that area. New York City, the New York City Well Hotline and the website will be able to give good information about harm reduction programs that are nearby. And this is a pamphlet from the DOH that's also a nice handout for patients if you're looking for something to print out. And more about naloxone programs. This is also a PDF that you can print out. And then some resources for Long Island and Ithaca as well. But you're welcome to contact us if you're not finding what you're looking for. We can help to point you in the right direction too. So with that, and sort of acknowledging all the people who contributed to the content of this session, and including Noah Kravchuk, who helped us put these slides together. So before we get to sort of the last item, which is to give a reminder and a quick overview of what we're doing this as part of about the overall project. This is information about CME. Either Noah or Adetayo, do you want to say anything more about this?
Yeah, I can say a little bit, and then Adetayo, maybe you could put this link in the chat. But just to note that participants need to log into the CME tracker through Northwell in order to access your CME transcripts. The certificates are not automatically emailed. And the link is here in the slide, and then also Adetayo will put it in the chat. And also the credits are only available to physicians, nurses, and physician's assistants. And when you log in, you'll see the title of the series is listed as Regional Approaches in Tertiary Care. But that is the official title of this CME course because we were added onto an existing course. So just to not be confused, that is the correct one. And if you have any questions about that, you can always email us at the study email. But yeah, Adetayo put the information in the chat, as well as the link to claim your CME credit for today.
Right. And so 1 minute overview of what we're doing here. So this activity, these lectures have been part of a study that's supported by the NIH, by the NIDA Clinical Trials Network, that is an implementation study looking at how the process of helping hospitals to develop systems for treating hospitalized patients with opioid use disorder, particularly treating them with medications for OUD. And we talk about it mostly as the HBOT study, the hospital-based opioid treatment study. And we'll be, with the rest of the study team, we'll be looking at Medicaid claims to see if there's any change in the post-discharge uptake of medications for OUD among hospitalized patients who have an OUD diagnosis. And we're able to look at other important health outcomes as well as healthcare utilization, again, using the Medicaid claims data. So New York is one of 4 hubs in the study. There's another one in Minnesota, Oregon, and Massachusetts. And each of us are working with 6 hospitals. And we're going to introduce the hospitals. This is the overview. So in the Northwell system, we have LIJ and South Shore. In the H&H system, we have Harlem and Kings County. Then we have Maimonides in Brooklyn and Cayuga in Ithaca. And I think we have some of the leaders from the different hospitals. So I'm going to suggest that we go down this list. And if you're here, Can you just speak up, introduce yourself so folks can hear and or see you? Dr. Garcia. I can't see who's here, so. I see you now.
Yes, I'm here. I'm chair of psychiatry here at South Shore University Hospital, and at South Shore University Hospital. So looking forward to continuing this process and improving the treatment of patients here.
Great. Samara.
Hi, can you hear me?
Yes.
Yeah, I'm Samara Touchton. I'm a nurse practitioner. I work with hospital medicine at Cayuga Medical Center, and I also do addiction medicine care at a local clinic in Tompkins County called Reach Medical. And we're in the process of getting an addiction medicine consult team up and running, and also in our hospital and utilizing a lot of the knowledge that you guys have given to us over the past couple of weeks. So thank you.
Thank you. Uche, are you up?
He's not on today. He let us know before.
All right. He's the lead from H&H from the Harlem site. What about Ken at LIJ?
Yeah, I'm here. Hello.
Hi.
I'm hospital medicine at LIJ, and we're, in the process of putting together, linking all of our various players who are to improve and increase HBOT in our hospital.
Fantastic. And from King's, Jennifer Mark? Or anyone? We may be missing them today too. I think I saw Ruben from Maimonides.
I'm here. Hi everyone, I'm Ruben Strayer. I'm an emergency physician primarily, also have an addiction clinic, and I've been pleased to represent Maimonides and participate in this collaborative, which we've used to really try to move our inpatient addiction care forward. So thanks everyone.
Thank you. And so thanks for speaking and just sort of helping folks to put a face to the name, and to know now that we're not convening these lectures, every other week, that you do have someone to reach out to locally if you want to know what's going on, or hopefully if you want to know how to get involved and to help the effort. So this is a reminder of how to reach our study team. We're here to help you with the efforts that you're doing locally, and this is how to reach us. And if you have questions about what the study is or what the activities are. And with that, I will say when we send this out, there's a long appendix of slides about naloxone training that you can use if you're ever doing training for a larger group. So we welcome you to just use those wherever it's helpful for you. I will stop sharing. We're right at 1 o'clock. But as usual, my team will hang out for a few minutes if anybody wants to stay on and has questions. But otherwise, we'll be sending out the recording and the slides in the next day or two. Thank you all for joining. It's been great to do these sessions with you. Really appreciate the participation.